Hi everyone, we are going to do our renal lecture today. So this is provisions of care associated with elimination. Our representative conditions for GU dysfunction are going to be a urinary tract infection. We're going to talk about nephrotic syndrome, acute glomerular nephritis, and Wilms tumor. First up, we will talk about a urinary tract infection, and we will look at some of the things that we see on assessment with a UTI. As far as the GI system, we could see vomiting, diarrhea, poor feeding. For GU signs and symptoms, we could see frequent voiding, a weak urine stream, dribbling, straining, foul-smelling urine, a persistent diaper rash. If this is a lower urinary tract infection, we'll see frequent painful urination, dysuria, urgency, and hematuria. If it's the upper part of the urinary tract that's infected, we'll see chills, fever, and flank pain. Another indicator would be incontinence in a potty-trained child. Some things to note: the reason we're talking about a UTI, it is one of the most common infections in childhood for the GU system. Also, uncircumcised males under 3 months, they do have a higher incidence of a urinary tract infection. What we could see their urine looking like is cloudy. It can be thick with strands of mucus and pus. If we send the urine for a culture, we'll see numerous white blood cells. We could see red blood cells possibly, and it could have an unpleasant odor as well. The things that we worry about with the urinary tract infection are high risk for injury related to possible kidney damage from recurrent infection, knowledge deficit regarding drug administration, and prevention of recurrent UTIs. The first thing that we have to do is obviously eliminate the infective organism. So the first thing we have to do is obtain a urine culture before doing anything. So make sure you're looking at the different ways that we collect urines on the different age of our pediatric population. If we have a diapered patient, we can use a urinary collection bag, also known as a PUC, P-U-C. And we typically put that on just prior to feeding, because typically when we feed an infant, that will stimulate them to urinate. And the bag can hang out the side of the diaper so you can see when there is urine in the bag. Those bags leak a lot, so as soon as you see urine, go ahead, take the bag off and get it sent to the lab. Again, for culture and sensitivity. Culture, what is in the urine, and sensitivity, what antibiotic is going to get rid of the organisms. So once we find that out, we would administer the appropriate antibiotic. Is it a penicillin? Is it a sulfa drug? Is it a cephalosporin? Whatever it is, make sure you're checking for allergic reactions or any allergies. And then again, making sure that we do some good teaching so that they know that they should finish all of the medication. The next thing that we want to talk about is health teaching, prevent recurrence. This is where we need to do some education. Again, depending on age, what type of perineal hygiene. Make sure they know how to clean properly. They should be wiping from the front to the back so they don't bring any organisms from the GI system into the GU system. They should avoid tight-fitting clothing. They should wear cotton undergarments. Encourage frequent voiding and emptying bladder completely. Again, establishing some regular voiding times. With toddlers especially, they enjoy playing. They don't want to stop to go to the bathroom. They don't want to stop to eat. So we have to remind them to do those things. Avoiding constipation, because constipation can be related to UTIs. Encourage generous intake of fluids to decrease bacterial growth, and they should avoid carbonated beverages if at all possible. So increase fluids overall. If we're talking about sexually active adolescents, they should void after sex, and avoiding bubble baths will also help prevent UTIs. And again, a thing to note here, as girls, just because of the anatomy and physiology of a girl. In the GU system, they do have an increased risk for a urinary tract infection as opposed to males. Your evaluation or outcome criteria would be that the infection has cleared and family complies with the treatment regimen and the child does not have a reoccurrence of the UTI. In some cases, we will have them do a follow-up UA just to make sure that we did get all of the infective organisms wiped out. It wouldn't be uncommon to have them go through a second dose of antibiotics if there is still something present on that UA with the culture and sensitivity. All right, you guys, the next thing that we are going to look at is nephrotic syndrome assessment. Trying to figure out what I'm saving for our review days and what I want to talk about now. Okay, so nephrotic syndrome assessment, and again, make sure you're kind of wrapping your head around nephrotic syndrome. You could see it as nephrosis. You could see it as MCNS, minimal change nephrotic syndrome. Make sure you're listing all three names so you know exactly what we're talking about. If you see nephrosis, think, oh, nephrotic syndrome. We're talking about nephrotic syndrome because it is the most common presentation of glomerular injury in children. What we have is some changes to the glomerular membrane in nephrotic syndrome. The membrane will become permeable to proteins, especially albumin, which is lost in the urine. So we have hyperalbuminuria, which leads to hypoalbuminemia. So lots of albumin in the urine, so not a lot of albumin in our blood, okay? What we see on assessment is weight gain greater than expected over several weeks. And again, kids kind of, their shoes are tighter, their clothing seems tight. That's how they're noticing that weight gain. And don't forget, the younger the child, edema presents periorbital. And then with nephrotic syndrome, it eventually leads to total body edema, and we call that anasarca. Your labs, you'll see massive proteinuria. You'll see, like we said, we'll see decrease in albumin in the blood. Hyperlipidemia, we see that as well. It isn't fully understood, but the thought is to believe that we have a decrease in our liver, so it increases synthesis of those lipoproteins, which causes hyperlipidemia. Don't forget, a lipoprotein causes both protein lipids, it carries both protein lipids and allows fats to move, okay? In general, we'll see urine is decreased, it's dark and foamy. Our patients will be pale, fatigued, anorexic due to loss of appetite and or diarrhea. Blood pressure could be normal or slightly decreased. They would have an increased susceptibility to infection. And again, one of the big hallmarks here is that massive urinary protein loss and the edema. If you guys, let's see, if you look on page, I think it's 1343, there is a figure 45-6, and it's a sequence of events in nephrotic syndrome, which causes us to the hyperlipidemia, the edema, and again, hypovolemia, because we're losing volume. So that's, and I'll go over that in class for the review session. And again, with nephrotic syndrome, we already said there's protein in the urine. It's albumin, so decreased albumin in the blood, hyperlipidemia, edema, and massive urinary protein loss. All right, our issues that we're going to work through as our nursing diagnoses: fluid volume excess related to shift of fluid from the plasma to the interstitial spaces. I know the diagram talks about hypovolemia. That's because we're losing volume where we want it. It's shifting into those interstitial spaces. We'll talk about altered nutrition, less than body requirements related to anorexia, high risk for impaired skin integrity related to edema and immobility. high risk for infection related to diminished body defenses, activity intolerance related to fatigue, and then knowledge deficit related to the disease process, treatment, and long-term care follow-up. All right, the first thing we're going to do is prevent fluid retention. To do this, we are going to administer a loop diuretic, typically furosemide. We want to make sure that we're quickly getting rid of that excess fluid. Then we also want to administer albumin. Remember we said albumin was low, and albumin helps keep everything in the spaces where it needs to be. If you think back to our burn lecture, remember we talked about giving our burn patients all of those fluids, but then we need to give them albumin because that balances out what should be in the interstitial spaces and inside the cells. We would also administer steroids here. Prednisone is typically what we give. And don't forget the side effects of steroids, some of the biggies: weight gain, behavioral changes, increase in appetite, round face, a higher susceptibility to infection. And don't forget, these kids are already susceptible to infection because of this nephrotic syndrome. So it's kind of like a double whammy. We would want to make sure we're doing daily weights and abdominal girth. Urine, strict I&O, we're checking the specific gravity and the protein with every void. And again, we can do that at the bedside with a dipstick if your unit is doing that. With the edema, you would want to make sure you're noting the extent of the edema, the location, and the progression. As far as their diet goes, for fluid retention, we would do some salt restrictions during periods of massive edema. They can have a regular diet when they're in remission. Fluid restriction is seldom necessary except during this extreme edematous period. And again, that would, remember, we're trying to get rid of that fluid. So we could see some fluid restrictions and some salt restrictions during these periods of massive edema. Our next nursing issue that we want to work through is providing adequate nutrition. Don't forget here, they just have a loss of appetite, and that'll lead to anorexia. Type of diet we'd like to do here is a high protein unless renal failure is present. Don't forget, protein is hard on the kidneys. So as long as we still have properly functioning kidneys, we can go ahead and go with a high protein. If we do have some renal failure present, it would be low to moderate protein depending on the extent of the injury. In order to provide adequate nutrition, you'd want to stimulate their appetite. We do that by offering choices, appropriate choices. What are some of their favorite foods? Find that out. And if they're appropriate, let's offer those. Small portions, make the meals as regular as possible. Can they eat a meal as a family? Can we bring in siblings to eat all together? And then again, don't forget, when you're doing any type of nutrition planning, make sure you're looking at if there's any cultural preferences that we need to work into that as well. Our next goal is maintaining skin integrity. We want to provide good skin care. We would want to turn and reposition frequently. Remember, they don't have any energy. They might not be up moving a lot. So we would want to turn and reposition and then monitor those areas that are more susceptible for skin breakdown. The edema also adds another layer to skin integrity. Skin can become so edematous that it starts to crack and weep. So make sure you're aware of what's edematous, and do I need to elevate that on pillows? What do I need to do with that? Don't forget to support edematous organs. A good example of this is scrotum. If we have anasarca, that total body edema, everything is edematous. So don't forget the scrotum if they become edematous. We typically put a washcloth underneath to prop them up to get them off of the mattress so they don't have any skin breakdown. And then don't forget, we talked about that periorbital edema. We want to make sure we're doing some good cleaning of the eyelids, getting those folds cleaned well, okay? So just make sure you're aware of that. Our next goal is to prevent further infection. Again, don't forget, we're worried about them being on steroids, and we're worried about their immune function already being diminished because of nephrotic syndrome. Make sure you're monitoring their vital signs. You're looking for elevations in temperature, heart rate, respiratory rate, what is their WBC doing. You want to use good hand washing technique. You want to limit contact with persons who are infectious. Administer antibiotics if there is an infection present. We want to keep them warm, keep them dry, and and make sure you're stressing good hygiene. And don't forget the other sites of infection. If they're not mobile, we're worried about lungs. If they're not getting up and moving, if they're not coughing and deep breathing, we're worried about skin again because of that skin breakdown. And if we don't notice those infections starting, it could become systemic. So it could be in the bloodstream. The other goal we have is to conserve the child's energy. We talked about how they're gonna have low energy. We want to make sure we're providing periods of rest between ambulation and activity, and provide age-appropriate diversional activities as they can tolerate those. Okay. The next thing that we're going to talk about is our health teaching for nephrosis upon discharge. We need to teach the child, if age-appropriate, and the family that the child is typically treated at home with supportive care. Hospitalizations are typically for the first diagnosis of nephrotic syndrome. After that, hopefully it can be managed in the home. Assessment and treatment of infection and responses to therapy, what medications we're going to administer and how they should respond to them. Teach general measures such as what diet to follow, what medications are they going home on. We'll need to arrange for some long-term follow-up care. And again, we would want to make sure we're addressing the concern for social isolation related to hospitalization and treatment. Some other things that we need to talk about: they may need follow-up urine cultures once they go home. Make sure they maintain adequate fluids at home. Again, adequate fluids will help dilute the urine, which will decrease bladder irritability, and fluids will also flush out bacteria. Make sure when we're doing our dietary teaching that we teach them to avoid caffeine, alcohol, citrus juices, chocolate, spicy foods. All of those things can irritate the bladder, so we'd want them to avoid those. And also, they may go home on a low-dose long-term antibiotics. We want to talk about that. Some other signs and symptoms, some other long-term side effects of steroids if they go home on steroids and they're going to be on them long-term, we would want to mention about hirsutism. And again, that's where hair grows in areas that it shouldn't. Side effects in our pediatric population: it can retard their growth. They're at risk for cataracts. They're at risk for elevated blood pressure. They're at risk for GI bleeds. They're at risk for their bones becoming demineralized, and that leads to fractures. And another thing that I'm not sure if I mentioned it earlier with steroids, but you guys should know this: it does increase the blood sugar. And we know with increased blood sugar, bacteria loves that sugar. So again, infection, infection, infection. Your evaluation outcome criteria for nephrotic syndrome is that you've maintained or restored a normal fluid balance, adequate nutrition is maintained, skin integrity is maintained, no secondary infections occur, energy is conserved, and that the child and the family verbalize their understanding of the disease, its treatment, and its prognosis. The prognosis is fair. Again, it's subject to long-term steroid use, and their prognosis would be related to any relapses they may have. 20% of these kids with nephrotic syndrome do ultimately end up suffering chronic renal failure.